Hey, welcome to the Healthful Woman Podcast, the fastest growing podcast in women's health. Today's Monday, February 24th, 2025. Today I'm joined by Dr. Katherine Ida Halper, who is one of the new terrific doctors in our practice. Dr. Halper, or KI as we call her, and I are going to talk today about what happens during a cesarean. We're going to cover what we do as surgeons, not too graphically, as well as what to expect as a patient undergoing a cesarean. Hopefully, this podcast will be a helpful one for anyone who has or will undergo a cesarean, as well as anyone else out there who's just curious what goes on during that operation. All right, thank you all for listening. See everyone next week.
Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. All right, Dr. Halper, KI, welcome to the podcast. This is your first time on the Healthful Woman podcast, so welcome aboard.
Thank you. Happy to be here.
It's good to have you. So you are a recent join to our practice. We are happy to have you aboard, and it's good for our listeners to meet you, those who are in the practice and those who are listening throughout the world, to know who you are, to meet you and get a little bit of your insight. We're going to talk today about cesarean deliveries and sort of what happens during a C-section. But first, just so people get a sense of who you are, give us a little background. Like, who are you? Where you're from? Where'd you go to school? Things of that sort. Open-ended question. Any way you want to answer is cool.
Okay, sure. So I grew up in New York City.
Cool.
So I'm happy to, be here for the long haul, hopefully. I went to medical school in Israel at Ben Gurion University. I then came back to New York, actually to Brooklyn for several years, where I was at Brooklyn Methodist Hospital, where I did my residency. I graduated this year, and then I just started here with MFMA in September. So
terrific.
It's been great so far.
The full circle back to the city.
And hopefully to stay.
Good job. So we've been happy to have you for the past several months, and as have our patients. And what's it like shifting from residency to like being the big boss in private practice? How's that transition working for you?
It definitely is an adjustment. In residency, you spend a lot of your time, I would say majority of your time, in the hospital, mainly on the labor floor or in the operating room, or taking care of patients on the floor while they're inpatient. Whereas, in private practice now, majority of the time, I would say, is seeing patients in the office, and then a couple days a week or so on labor and delivery or in the hospital doing other things. So it's definitely a shift as far as how I spend the time. So it's, it's exciting, it's different, but it's the same, seeing the same things in sort of a different setting.
Yeah. And I think that's, a lot of people don't really understand what happens during residency. You are based in a hospital. There's outpatient experiences in a hospital. There are like offices and clinics and whatnot. But as a resident, so much of what you're doing is learning how to do things, right? And so you have to learn how to operate, learn how to deliver babies. And so much has to be done in the operating room. And it's part of the reason that I wanted to do this podcast to talk about C-sections, because, C-section is a major operation, from our end, right? Where it's surgery, it's the real deal. And I don't know if people appreciate how many of these we do in training in order to get good at them. So if you were to estimate, like, how many C-sections do you do during your residency, would you guess?
I would say somewhere in the 300s, at least.
Yeah, many hundreds, right? It's not like
maybe
5.
More.
Yeah, it's a lot.
Yeah. It's definitely a good amount. And you start from the beginning of your intern year, pretty much. I think I started in my 3rd month of residency. So
right. And it sort of gets to the point during your training that by the time you finish, like, like the steps of a C, like when you dictate a C-section, when the steps are like 1, 2, 3. You know them like the back of your hand. You know them like you could be woken up at 3 a.m. and someone say like what clamp to use for this? Like, nope, that's a coker. I know. And it's just like it's really become second nature, which is important because when you're operating, so much of it is muscle memory and knowing where to stand and where to turn your hands and where to do this and what to look for and what to think for. And you have to do a lot of them to get good at them. And so I think that sometimes when we as doctors talk to patients about C-sections, we sometimes forget that they don't know anything about it. They have no idea what's going to happen, right? They know they're going to go in the operating room, we're going to do something, and a baby's coming out of their belly, and then they leave, right? And so I was hoping for this podcast, we could sort of not in a guts and gore kind of way, but just sort of go through what someone can expect for what's going to happen if they're going to have a C-section, both sort of from their perspective as the patient, like their experience, what they're going to see, what they're going to feel, what's going to happen. And from our perspective, what we're doing, just so they get some clarity. And there's probably some stuff online on this, but this might be hopefully a little bit less terrifying.
Totally. And I think what's really interesting about C-sections compared to pretty much every other surgery is you're actually awake for it.
Yeah.
So that is, something that kind of sets this type of surgery apart from most other surgeries that people will have in their lifetime.
Yeah. And that's something that I talk to patients about, but I always, like when I'm operating with residents, I remind the residents, I'm like, hey, this person's awake, right? So when we walk in there and we banter with each other and we're talking and we're just cool. Like, we talk about this, we talk about whatever, we talk about the operation itself, we talk about just nonsense. They're listening, right? So be very careful. Like we don't want to say things like, oops, never seen that before, right? These are things you don't want to say. Hopefully it don't happen, but obviously you don't want to say it because you don't want to freak anyone out. You just want to, keep everyone aware that everyone in the room is awake, hopefully. That's the plan.
Totally. What's also nice about it, I feel like, is you can actually continue to communicate with the patient the whole time. So, you can check in, they can ask questions, you can, at least have some communication, which again is not something that you can do in almost any other surgery.
Yeah. I mean, you see things are going great. Everything looks good. We'll be, baby will be out in 5 minutes, all those things so people can sort of that. And as the patient said, you're allowed to talk. You're allowed to ask questions. I mean, obviously, if they're busy and concentrating on something, it depends on the circumstance, what's going on. But you could say, hey, like, what's going on? Is everything okay? I feel this, I feel that. Is that normal? That's totally okay. And either the surgeon will answer, or maybe the anesthesiologist, or maybe one of the nurses, again, depending on the question and the circumstances. So let's talk about before the surgery, right? So there's sort of, I think we could divide up into like preoperative, what we call sort of, which is before the surgery, then in the operating room, before we start, while we're doing it, and then after it's finished. So preoperative, right? Someone's about to have a C-section. This obviously might differ based on whether it's a planned C-section, right? Someone says, I'm going to the hospital on Tuesday to have a C-section versus someone who's in labor and we switch plans. We say for reasons A, B, or C, we have to switch and do a C-section. But okay, what are the things that we do and patients can expect to happen before surgery, preoperatively?
So before the surgery, one of the things we'll do is we'll scan the baby. We want to know what position the baby's in so that we know what to expect when we go in. We will also do some basic blood work just to make sure we kind of know our starting blood count. We know the blood type. We have blood available if needed so that we're just, prepped and ready to go. With any kind of surgery, there's always a risk of bleeding. So we like to just be prepared. Other things that we think about, we want to just make sure that we know the whole complete medical history, surgical history of the patient. Anyone who's had multiple prior surgeries, we can expect that there could be some scar tissue, that the surgery could just take us a little bit more time. We like to just sort of at least set expectations, both for us to be on the same page with the patient and with everyone else in the room. We also obviously give everyone a chance to ask questions, to, come up with any, last things that they want to go over before the surgery. And we usually sign the consent form and just go through everything one last time.
Yeah, I mean, ideally before surgery, it's intended to be a time that we're trying to reduce anxiety, to make people feel more relaxed. Because going into surgery is obviously anxiety provoking for everybody. That's totally normal. And so having that, and again, and usually if it's planned, we've already spoken about it even in the office and for days or weeks or whatever. But it's really nice to people come with questions or people forget something and they want to have an opportunity. It gives them a nice chance also. Usually they get to meet the nurse beforehand, the anesthesiologist. And again, unless someone's already in labor, they're typically walking into an operating room, right? We don't have to wheel them in. They don't get put to sleep or anything like that. There's not, it's really meant to be something that's as less scary as possible under the circumstances. And so having conversations on the front end definitely allows us to do this. And then on our end, there's definitely, like you said, things we want to check, to make sure that everything's okay and set expectations. How much time is it going to take? Do we need more surgeons there? Do you need more equipment there? Whatever. And in rare circumstances, there's things that we might need. Usually not, but that's a possibility. So that's all preoperative. Everything is set up. What happens when someone walks into the operating room for their C-section? Or they're rolled in if they're in labor?
Right. So it kind of depends. If they are walking in, the first thing that we're going to do is, get them set up and comfortable on the operating room table, introduce them to anesthesia once again, and get them ready to get into position for their epidural placement.
Right.
So that is on the side of those who are coming in for their planned C-section. If they're wheeling in, they already have an epidural in place. So usually at that point, we kind of get you situated on the table and then start our prep procedure a little bit more quickly.
Right. And usually for this part of the preparation, we usually bring people in alone without their partner. So why is that? Like why we have someone wait outside rather than having them come in together?
Well, so we have a lot of things that we need to do, a lot of OR personnel who are also getting everything set up. We have our table that we're getting set up with all the sterile instruments and making sure all of our prep is set up. We are listening to the baby. That's one of the things that we do. We get you connected to some monitors. We're placing, if you don't have an epidural already, a Foley catheter after the epidural comes in. So we have a bunch of kind of tasks where people are moving sort of in a very sort of like rhythmic way that we're used to, but having an additional person in the operating room, I think would just kind of potentially upset that rhythm a little bit. And I think also keeping the partner a little bit separate from some of the more kind of clinical and like measurements and prep work is kind of better. Instead, they come in when the patient's already set up on the table. They go behind the curtain with the patient and the anesthesia team. And we keep them sort of separate from the actual surgical aspect.
Yeah, I think that's a good point. I think it's unusual in general when people are having surgery that anyone goes in an operating room with them, right? People go into operating rooms alone and they come out alone, right? That's very typical. C-sections are obviously unique because number one, the patient's awake. And number two, there's a baby being born here. And so that's a very special event in addition to surgery. And so we're trying to balance sort of keeping it a happy and light and sort of joyous moment on the one hand, but on the other hand, not forgetting that this is surgery, this is serious. Like we have like sterile technique, like there's things we have to do to keep it safe. And I think that I agree that having someone in the room while we're doing all these technical things could be logistically complicated. Sometimes they bump into the wrong thing and then something's not sterile or, someone is doing something and it feels like they've been slighted and they get offended. Like all these things happen. But also, it's a little disconcerting. It's like scary to see someone getting set up for surgery. We have to like disrobe them and we have to like move them. And then with the spinal, they can't really move themselves. We have to like move their body. And it's hard to watch a loved one get prepped for surgery. And so we sort of want it to be like we get everything set up, get all the drapes on, it's nice and blue and everything looks perfect and clean and neat. And then the partner walks in and like sits down and everyone's blood pressure is nice and no one's pulse is going up because of this. And I mean the two people at the other end of the curtain, the patient and her partner. Like for us, it's not, it doesn't, no sweat off our back if someone's watching us. It's not an issue, but it tends to be a little bit calmer that way. What I find, it's very similar to sort of like a lot of times when someone's having their epidural placed, they'll either ask the partner to step out of the labor room or sit down on a chair and not see, because you also don't want someone getting lightheaded or, we don't want any partners passing out in the operating room. That's not a pleasant day when that happens. So but that's something to expect, that usually you go into the operating room alone, but assuming you're awake for the operation, your partner will join you after the prep is done before we start. And for the person who's waiting outside, it can sometimes feel like a long time. It's not like 2 minutes.
Yeah. I usually like to tell people expect to sit here for, 15, 20 minutes. Great.
Yeah.
If it's faster, amazing. But that we just have to do our usual setup, our usual prep. It's all just the stuff that we do all the time. And that, they're not going to miss any of the action.
Right.
But we will call them in when it is their time.
Right. And another thing that sometimes people are surprised to hear is we have these things in the operating room we call timeouts. Someone will yell like timeout. Can you explain what that is so people that aren't wondering why there's a sporting event going on in the middle of their surgery?
Sure. The timeout is the opportunity for all of us, all of the operating room personnel, the doctors, the nurses, the pediatricians, who, by the way, are in every single C-section. Just wanted to mention that they're there no matter what.
In our hospital, not in every hospital.
Oh, sorry.
Yeah.
And the anesthesia team, scrub techs, everyone is on the same page about, we're confirming the patient who we're performing surgery on. We are confirming, the medical situation, the indication for the C-section. We are just making sure that everyone is on the exact same page before we start to make sure that this can be done as safely and smoothly as possible.
Yeah, I mean, timeouts sort of classically started for things like patient's asleep, we're about to replace a knee. Does everyone agree that we're doing the left knee, not the right knee? So you don't accidentally replace the wrong knee. And that's like the classic, like, oh my God, like, do not get this wrong. And so you would say like, well, we're not going to do a C-section on the wrong, part of the body. Like, and so, but so maybe that part isn't as relevant for a C-section, but were antibiotics given? Do they need to be given? Is there anything special we need to do with the placenta? Are like sort of everyone's just sort of on the same page. And also what's nice is we all introduce ourselves by name. We go around the room and everyone says who they are. It's like roll call. And because you don't always know, there could be 12 people in the room and the patient doesn't know, and maybe not all the doctors and nurses know who everyone is. Like, is she from anesthesia or is she from pediatrics? And so it's nice for everyone to sort of do that because there's a lot of people working in a hospital and you don't always know. So that's something to expect. And usually there's at least one and sometimes two of those in the operating room before we start. We do something called an instrument count, where you'll hear someone saying like, 2 of this, 4 of this, 6 of this, 8 of this. And that's just to make sure that the same number of instruments coming in are the ones coming out. So we didn't leave an instrument behind, so to speak. That's an important part of it. And we always check that the anesthesia is working at this point several times. But that's another concern people have before surgery. Like, how do I know this isn't going to hurt?
Yeah. So that is definitely something that we make sure of before we start. But it's also important to remember in a C-section, yes, we test you to make sure you don't feel anything sharp. But the thing that I always tell people is, yes, you're very numb, but you're still going to feel things going on. You're still going to feel touching and sometimes pulling and pressure. And those sensations we don't take that away.
Right.
So just setting that expectation in terms of, no, you shouldn't feel sharp. And we make sure of that before we start. But you will feel something.
Right. And the other thing that happens that is sometimes people forget is between the patient being sort of ready and in position and us doing all of the prep work, we have to leave the operating room and then come back in because we have to wash our hands. The surgical scrub, as it's called. So it's to be expected that you'll have all these people in the room and then your doctors are going to leave you for a couple of minutes and then come back, usually with wet hands, fingers pointed to the ceiling. So, you want us to be sterile when we start this operation. So, okay. So we're all prepped. We put all the drapes on. The partner comes in and then we're about to start. And so what happens at that point?
When we take the first incision, you might hear someone say skin. That just alerts everyone in the room that we are actually starting the surgery itself, just so that everyone can be aware when the procedure actually began. Basically, at that point, we make our skin incision and then we kind of continue through the various layers of the abdominal wall, which is we go through fat, we go through fascia, we go through muscle, peritoneum, which is the sort of like lining that in front of the internal organs, and then we get to uterus.
So from the patient's end, how long does that take from when we start to when we're about to deliver the baby?
It's a great question. This can really depend on how many C-sections you've had in the past or how many abdominal surgeries. And someone who it's first surgery ever, anatomy should be pretty much exactly as you were born with. So getting down to baby can be, anywhere from 3 to 10 minutes in those situations, I'd say. Or if it's a very urgent situation, sometimes even under a minute.
Right.
But in those people who have had multiple prior surgeries or many more C-sections, that time can be quite a bit longer, sometimes more in the range of 15, 20 minutes. And that is expected because there can be scar tissue that we, have to go layer by layer and very carefully go through in order to safely get to the uterus.
Right. And so from the patient's end, so there's the time aspect. And what should her sensations be at that time? So she's not going to feel sharp pain, and we check for that multiple times. So what might she feel while this is happening?
Yeah. So in the beginning, you might just feel some like pushing and touching.
Mm-hmm.
And then when we get closer down more towards the muscle, you might feel some like tugging and pulling and like kind of stretching.
Right. And then a lot of people during this time report that they have like lightheadedness or dizziness. Is that related to the surgery, or is that more the anesthesia?
It's usually related to the anesthesia.
Right. So what's going on, and what should people expect with that?
So the epidural anesthesia can lower the blood pressure. It can make people feel dizzy. Also, depending on the type of medication that they're dosing you with, it can be pretty like medication, which can the side effects can make you feel nauseous. Sometimes people will have nausea or vomit on the table, which can be an unpleasant sensation.
Yeah.
But it can be part of the experience, unfortunately.
Is that something that they can treat typically?
Yes, they can give anti-nausea medications, which can be helpful, but sometimes people will still feel uncomfortable throughout the process.
Yeah, I would say it's important. And usually the anesthesiologist will say to you, like, let me know if you feel nauseous or dizzy, and they can either give you nausea medicine or sometimes raise your blood pressure to fix it. But that's something that if they haven't asked you that, but you're feeling that, you can speak up. Again, you wait, you'd say, hey, I'm a little dizzy here, I'm a little nauseous. Is there something you can do? And usually it's something they can address pretty quickly. But again, that's not usually from the surgery part. There are other times in surgery that might be the case, but not for this part. So, okay, so we're at the uterus, right? And so what should people expect at that point, and what do we do at that point? So now that we're looking at the uterus.
Okay. So at that point, we are ready to make our incision, which is going to be our big time action of the surgery, the exciting moment. So that usually takes about maybe 20 seconds to kind of get through the layer of the uterine wall to the baby. Once we get through, basically we expand the space to get our hand in to either deliver the baby's feet or butt or head, depending on the position of the baby. And at that point, basically, once we have what we call the presenting part, which is the part that's at the uterine incision, you're going to feel tons of pressure on your belly, which is called a sort of a fundal pressure. And that is going to help to get the baby out. But a lot of people describe it as a very intense pressure on their belly.
Mm-hmm. And that's because someone's generally pushing on their belly.
Yes.
Yeah. It's very accurately described as pressure on the belly. And then a lot of people ask if they can see the birth. So is that an option?
So that is an option. We have a drape set up so that basically if you want to see the baby actually coming out, we can drop the blue curtain and there's a clear drape, which you can see through for the actual delivery portion.
Right. And it's pretty cool. It could be freaky for some people as well. And so that's a choice to make for both you as the patient and your partner. And then, so we deliver the baby, and then what do we do?
So at that point, ideally, if everything is great, we can do a delayed cord clamping for a minute. Mm-hmm. And at that point, we'll hand the baby off to the pediatricians for evaluation, just to make sure that baby has good vital signs, is crying, is vigorous, is doing all the things that we want the baby to do on first landing into the world. Right.
At this point, someone's always going to ask, how much does the baby weigh before we weigh the baby? So that's a very typical thing. How much does the baby weigh? We haven't weighed the baby yet. And then, as Mike Silverstein always says, the top question is, why is the baby crying so much? And we always say it's a good thing. And the second most common question is, why isn't the baby crying so much? And we say it's fine. But something to remember is that at this point, so after we've delivered the baby, we're not taking care of the baby, right? We're focused on you because we've just opened your uterus and taken out your placenta, and there's bleeding and there's sewing. There's a lot of things. It gets very busy for us at that point. And so we may not be as attentive to your questions as you might like during those next 5 minutes or so, because there's a lot of things we have to do to keep you from bleeding. So what are the things that we have to do after the baby's out that we really start working fast?
Right. I think that's actually a really great point, and something that a lot of people forget, that the pediatricians are now in charge of the baby and we are in charge of you and keeping you safe. So the first thing we have to do is to deliver the placenta. So that usually happens within a minute or two of the baby coming out. And at that point, what we'll do is we want to get the bleeding under control. So the first thing we have to do is, close the uterus. But many of us, in order to close the uterus and get a really good look at everything, will do it's called exteriorizing. I'm saying that with quotes, but basically where we lift the uterus sort of and out of the belly. It's still connected to you, don't worry. But we lift it out so we can get really good visualization. We clean it out to make sure there's no pieces of placenta left inside to the best of our abilities. And then we will start closing it.
Yeah, that's something that most patients and partners don't want to see. It's like when you have a med student who's there for their first C-section and you exteriorize the uterus, and there's literally this internal organ, uterus, tubes, ovaries, just sitting on your belly and literally sitting right on top of it, and we're operating on it outside the abdomen. They're like, oh my God. But no, it's something that we don't do it in all cases. It depends on the circumstances, but it is anatomically, it's a pretty cool thing. Medically, it's a pretty cool thing, but it's a little freaky if you're not trained. But that's something we sometimes do. So it's usually at that point after the baby's born that we'll typically put that drape back up, ask the partner to sit down, look at the baby, focus on the baby. Don't look over here. We're going to do our thing and do that. And we're working quickly because, again, the faster we close the uterus, the quicker the uterus contracts, the less bleeding there is and whatnot. So those are things and if we don't exteriorize the uterus, it's still the same things, but it's just we're operating, everything's inside the abdomen versus outside. So, okay, so we close the uterus, and what do we do next?
Okay, so we've closed the uterus. We usually put it back inside after we've looked around.
I would say we always put it back inside. But that's good. We're going to keep that. All right. We usually put it back inside. I would say always, but that's fine. It's done differently. Maybe in Brooklyn, they usually put it back inside and then leave it out the rest of the time. There we go. See, I got Dr. Halper with the funny. Got her to laugh. Good job. All right.
Yes, we put the uterus back inside, and then we work on closing the remainder of the layers. And there's different evidence out there. People do this different ways, but I know that many of us in our practice really like to close every single layer that we've opened.
We're fastidious.
Mm-hmm. And we close everything that we can do safely. Obviously, there are some situations, like I mentioned before, when there's a lot of scar tissue, when someone's had many surgeries in the past, where it's not doable to close each layer by layer, but we do as much as we can.
Right. And the disagreement about this is sort of, on the one hand, the argument is, everything you open, you should close, put it back the way you found it, those types of things. And there's a lot of logic to that. On the other side of the argument is you might not need to close all those layers because they'll heal on their own. And maybe you're just taking more time and prolonging the operation, which may have some risk. And there's some validity to that as well. And there have been studies looking at each individual layer, which ones matter, which ones don't. And the short answer is nobody knows 100% any of these things. You have to close the uterus, you have to close the fascia, you have to close the skin. All the other ones are sort of, I don't want to say optional, but people disagree about them. We tend to close all of them, like you said, if we can. That takes a lot more time than opening them. Putting things back together takes a lot more time than opening them up, as it turns out. So how long should patients expect? Let's say you said it's 3 to 10 minutes from opening the skin to getting to the uterus. How about the reverse? From the uterus, getting back to closing the skin, how much time would it typically take on a first C-section?
I would say probably in the range of around 30 to 45 minutes.
Yeah, it's a lot longer. It's a lot longer on the back end than the front end.
For a first C-section, could be longer in a repeat C-section. Kind of depends on the situation. But I usually tell people just in general in the operating room with a C-section to expect at least surgery to take at least 45 minutes to an hour, but know that that time can always be longer. We like to take our time. We don't want to rush. So, whatever it takes to do it safely is what we're going to do. And also OR time door to door can be more like 2 hours between getting you into the operating room, getting you set up, getting, the surgery done, and then getting everything cleaned up too. So, the operative time itself might not actually be as long as the full time of the door to door full procedure.
Yeah, it's a really good point. Like I tell patients the same thing I said for you, getting operated on from we say we're starting to we say we're finished. It could be 30 minutes, 45 minutes, 60 minutes, whatever, based on the surgery. But for your loved ones who are in the waiting room and the hallway at home, when you text them, I'm going in, and then you text them, I'm now in the recovery room, it could be 2 to 3 hours because going into the operating room, all the prep time, all the things that we do before surgery and after surgery, which aren't surgery, but for someone who's at home, they have no idea what we're doing. So to warn them that it might be longer than that, which is normal from sort of their end of the experience. When we're closing, there's sometimes some nausea that happens that's not related to blood pressure. And I think that's a unique thing that it could be related to the surgery because some of the layers we operate on when we close them are a little more sensitive. So sometimes that's a different kind of nausea. So that's something that some people will experience during the surgery. And that's, just important to expect. And then when we close, right, no one's going to sort of see what we're doing, obviously. They just see the incision right afterwards. So how do we close the skin typically, like the final part?
Mm-hmm. Yeah. So that's what everyone always thinks about. So that we majority of the time close with a suture that actually goes underneath the skin. So you won't even see it. It dissolves on its own. It's not something where it has to be cut or removed. And the goal of that is basically to get the skin edges to come together nicely so that you don't see anything and it hopefully heals very well. So, that is, I know, the layer that everyone is most concerned with. Although for us, the most important layers that we're concerned with are the uterus and the fascia to make sure everything is nice and tight inside and no bleeding. But yeah, skin generally, like I mentioned, underneath the skin. We don't typically use staples. That is a very rare situation. I don't even think I've ever closed the skin with staples in the C-section.
Yeah, that's a change. And when I was 120 years ago, when I was a resident, we closed everyone with staples.
Interesting.
And then during my residency is when people started doing more of the suturing. And then I would say probably in my first 10 years in practice, it went from 95% staples to 95% plus sutures, certainly in our hospital and probably nationally is what I would guess. I don't know the numbers nationally, but I think most people don't have staples anymore. I mean, you could, they're fine. It's just there's a slightly better results in terms of pain and cosmetic with the sutures. And since you don't have to remove them, the staples you have to remove at some point, usually before you go home from the hospital. If you remove them, the wound can open up again. So it's a little bit more likely with staples. So there's advantages to sutures that we like, and that's what we do predominantly. Like you said, it's been for a transverse incision, meaning from side to side, I can't remember the last time I did staples. Same thing. Up and down incisions are a little different because they need a little bit more security, I guess. Okay, so now we've closed the incision. What happens at this point?
So at this point is usually when we ask the partner if they are still in the operating room or support person, whoever's in there, to leave the room because now, the surgery is over, but also we're, cleaning things up. That's when we see that there's like a little bit of blood. We're getting all those things cleaned up. That's just, not the most, fun part probably for the partner to be a part of. So we'll ask them to leave the room and we'll get the patient cleaned up. First, we'll put our dressing on. Usually what we do is we put what are called steri strips. It's little pieces of tape that just help keep the skin together and cover the incision. And those usually stay on for about 1 to 2 weeks. And then we put either an abdominal pad or gauze over the incision and put like a tape over it.
And that just stays on for like a day or two.
Yep, exactly. And then we'll get the patient all cleaned up and bring them to the recovery room.
With the baby, usually. Yeah, unless the baby has to go to the NICU for some reason. Typically, the baby's in the operating room till the end and goes to the recovery room with mom. And the only time that they really get, again, unless the baby has to go to the NICU, the only time they really get separated is usually the baby has to go to the nursery at some point there's an exam and they do some measurements and this or that. And so that happens at some point when mom goes to the recovery room. And that's really the only time that they're separate from each other. And then after that, the baby could be with mom the entire time, or unless the mom wants a baby in the nursery, that's sort of, based on what's going on in the situation. But they don't have to be separated because of a C-section. They're together pretty much the whole time. And also, we're comfortable with mom holding the baby during the latter part of the C-section. If her arms are free and she's comfortable, she can do that sometimes. If she's not, if she's tired or dizzy and doesn't want to do that, the partner can do that. And, once the baby's checked out by the pediatricians, it's not really different from a vaginal delivery. The baby just hangs out there until mom's ready to go out of the operating room. And then after the C-section, where does mom go?
After the C-section, mom will go just not even really down the hall, just across the hall to the recovery room, where she'll stay for about 2 hours typically. And that's because you get a closer level of monitoring after surgery, just to monitor your vital signs, so your heart rate, your respiratory rate, your blood pressure, just make sure that everything is stable after surgery. And you're on a monitored bed, so you'll still be attached to a heart monitor, various things like that. We'll continue to monitor your, like your urine and your pain and your bleeding, just in the kind of immediate stage in a much kind of closer observational setting.
Yeah. And then at some point you go up to your room, your postpartum room.
Yeah.
And they stay for a couple of days and then you go home, hopefully.
Yeah.
All is well. Good job.
And sometimes that's even just 40. A lot of people will ask me how long they'll stay in the hospital after a C-section, actually. So typically, assuming everything is straightforward, 2 to 3 days is typical. 2 days if everything is perfect. 3 days is totally fine too. But usually 2 to 3 days is the norm.
If things aren't perfect and someone's recovering slower than 4 days, we send you home when you're ready.
Exactly.
And so on average, it's about 3 days. So good. All right. KI, Dr. Halper, thanks for coming on the podcast. How was it? Your first podcast here. Was it okay?
It was good. It was great.
She's a natural.
Thank you for having me here today.
Awesome.
Thank you for listening to the Healthful Woman Podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.